Hey guys, just checking that you can hear me as always. So type yes or type hello in the comment section if you can hear me before we get started. Also, you can share this link. As you can share this link with friends or any WhatsApp group you run. Share this link and get as many colleagues as possible to join the free session, which is meant to update you on some of the changes that have gone on since the new BNF was printed. So if you've got any WhatsApp groups you run, you can share this link with anybody and say hi in the comment section if you can hear me so that we can get started. Okay, I'm just waiting for a few more people to join and we can get started. Share this link with anybody you would like to invite to this session. It's a free session, like I said, and we're looking at some of the changes that have taken place since the last BNF was printed. So the last BNF is this one here, which is BNF 80, and there's a new BNF now, which is BNF 81. So obviously for your exam, you want to use the latest resource and you want to get the latest information for your exam. Okay, so guys, today we're looking at BNF changes in the new BNF 81, but also what I've done for this session is I've included some of the changes online as well. So as you know, every month the BNF gets updated online, right? And the GPHC wants us to use the latest resource for the exam, which means you need to be aware of what's happening since the last one was printed. So that's what we'll be doing today. So in addition to that, there's a few questions in this session. As always, I like asking a lot of questions. It's great for your revision. As someone who's going to be seeing the period exam in July or even in November. So try and get involved, answer questions, ask me questions if you have any questions as we go along. And I'll do well, try as much as possible to respond. Okay, so we are going to be looking at about 10 drugs today, which is, I guess, is good and bad news. Good news because there isn't that many changes that have happened that is sort of relevant to your exam. So the link in the description should take you to BNF/NICE material, which is where I've got this information from. Okay, so there's a link in the description section, description that will take you to the information that you need to know for your exam, right? So we have got all the summary for this particular session, so you can have a look at that link later on. But what I'm saying is, this is a combination of what's on that link plus what's in the new BNF 81. So we're looking at 10 drugs and 10 changes that are relevant to your exam. And there's questions embedded in this session as well for anyone who has just joined us. I can see a few people have just joined. There's questions embedded in this session. Okay, first drug is erythromycin. Erythromycin is a macrolide, as you know. Before this change was made, you can give erythromycin, you can give amoxicillin, and you can give cephalexin in pregnancy, and they're both regarded as safe, right? So those three form the safest drugs we can give in pregnancy. Obviously, there's other drugs we can give in pregnancy that are safe as well, but it depends on the trimester of the patient. So something like trimethoprim, for example, which trimester should we avoid giving trimethoprim in pregnancy? Which trimester must you avoid giving trimethoprim in pregnancy? Tell us in the comment section if you know. Trimethoprim, which trimester should we avoid giving trimethoprim in pregnancy? Let us know in the comment section if you know what the answer is. Let us know in the comment section. Trimethoprim. Which trimester? Yeah, okay. So the correct answer is first trimester. The correct answer is first trimester. And it's the reason I've asked you that. The reason I've used trimethoprim as an example is because with some antibiotics, we have to avoid them in pregnancy completely. Some antibiotics we can use in certain trimesters, but not in other trimesters. And some antibiotics are generally regarded as safe in pregnancy. Okay, so before now, amoxicillin, cephalexin, and erythromycin regarded as safe. But just recently, they've updated their guidelines to say that erythromycin can actually cause harm in pregnancy. So when I went to work on Monday, I actually looked at one of the leaflets, or two leaflets, a leaflet from a new box of erythromycin we just received from our delivery, and a box from about 2 months ago that was still sitting on the shelf. And the box from about 2 months ago has in the patient information leaflet that it's safe in pregnancy. Obviously, speak to your doctor, but it's okay to take that in pregnancy. Whereas the new one now says that erythromycin can harm your unborn baby. So that is something you need to be aware of for your exam. So we can only use erythromycin if the benefits outweighs the risk in pregnancy. This is a new change. If the benefits outweigh the risk in pregnancy. As we know, erythromycin can cause QT prolongation. All macrolides can cause QT prolongation. This is not necessarily new, but this is something they've emphasized. It's something they've emphasized on again, which is something you're supposed to know before now anyway. So all macrolides, including erythromycin, can prolong QT. So we have to watch out for interactions. What other drugs can prolong QT that you can think of? Can you think of any example of drugs that can prolong QT? Tell us in the comment section if you can think of any drugs that would prolong QT. Which drugs would prolong QT? Can you think of any examples of QT prolongation, drugs that would prolong QT? Tell us in the comment section. So I have one example so far from Nikki. Nikki says quinolones. Yes, that's correct. So quinolones like ciprofloxacin or fluoxetine, they can prolong QT. Haloperidol, correct. Sophie says haloperidol can prolong QT. That's true. Anything else? Anything else? What else would prolong QT? What else? You need to know examples of drugs that will prolong QT because they ask questions like this in GPHC exam. Another example is domperidone. Domperidone is another example. Sotalol is another example. Loperamide is another example. Yes, Saka says loperamide. That's correct. So these drugs can prolong QT. You need to watch out for other drugs. If a patient is taking multiple medicines, you need to watch out for other drugs that can possibly prolong QT. And then lastly, there's now a new interaction that's been added in BNF. New interaction, which is an interaction between erythromycin and rivaroxaban. Erythromycin and rivaroxaban. You know, erythromycin is an enzyme inhibitor. Erythromycin is an enzyme inhibitor, so they would interact with things like simvastatin, for example, and cause muscle pain or muscle breakdown. So this is a new one you need to know, interaction with rivaroxaban. Before now, we know that erythromycin would interact with edoxaban. So edoxaban is one of the NOACs. Edoxaban is one of the NOACs. One of the NOACs. Is edoxaban normally taken twice a day or once a day? Edoxaban, is it normally twice a day or once a day? Who knows? Tell us in the comment section if edoxaban should be taken once a day or twice a day. Once a day or twice a day? Once a day, correct. Yes. So edoxaban should be taken once daily. This is correct, yes. So out of the 4 NOACs that we can use, edoxaban should be taken once a day. Rivaroxaban should be taken once a day. Apixaban and dabigatran can be taken or should be taken twice a day. Yes, so if you looked at the new NICE guidelines on the treatment of the prevention, secondary prevention of cardiovascular events in patients who have had strokes already, that new NICE guidelines that came out about a couple of months ago said we should use the twice a day NOACs before the once a day NOACs. Yes, twice a day NOACs before the once a day NOACs. So give things like apixaban and dabigatran first before things like edoxaban and rivaroxaban. That is what the new NICE guidelines on the prevention of secondary events after a patient has stroke says. So yes, so interaction with rivaroxaban and erythromycin is a new drug interaction that's been added. So if it's not in the new BNF 81, which you should have, it should be online. It should be online because this session, for anyone who has just joined us, is a combination of what's online and what's in the new BNF, basically the latest information. Next, we'll talk about pregabalin. Pregabalin, they've added a new finding from a research that pregabalin, especially brand Lyrica, can cause respiratory depression. So before now, we know from 2017 that gabapentin can also cause respiratory depression. So now they've added that Lyrica, which is a brand of pregabalin, can also cause respiratory depression. So what other drugs can cause respiratory depression that you can think of? Can you think of any examples of drugs that can cause respiratory depression, which can then interact with pregabalin? Tell us, respiratory depression. What drugs can cause respiratory depression that you can think of? Opioids, yes. Opioids like morphine, that's correct. Anything else? What else can cause respiratory depression? So I've told you 2 already. I've told you gabapentin. Now they've added pregabalin. Opioids, so opioids like codeine, morphine, oxycodone, they will cause respiratory depression. Anything else? Anything else? Antipsychotic drugs. Some antipsychotic drugs can cause respiratory depression. Some antipsychotic drugs can cause respiratory depression. Yes. So you need to watch out for your exam. They would ask you about opioids because that's the most popular one. So watch out for drug interactions between something like gabapentin or pregabalin and the patient taking opioids, for example. Good. Next, we'll look at PPIs. We'll look at PPIs. In the last session we had about two weeks ago, we talked about PPIs, and we talked about PPIs in general. We talked about pregnancy and PPIs, and we said omeprazole is the only safe PPI in pregnancy, right? So the other ones should be avoided in pregnancy, but omeprazole is the only safe only safe PPI in pregnancy. Now, before now, the other PPIs couldn't be given in breastfeeding either, so it couldn't be given to breastfeeding mothers either. But from March this year, they've added in the new BNF that mothers who are breastfeeding can now take things like pantoprazole, they can take lansoprazole, they can take rabiprazole. Okay, so it's all in the link in the description area just under this video. You can click and have a look at it later on, but this is brand new. They've added that breastfeeding mothers can now take lansoprazole, omeprazole, pantoprazole, rabiprazole. So BPIs basically they can take. So this is brand new. But for your exam, also you need to know about the complications of PPI. We talked about the complications of PPI before. Can anyone tell us 5 long-term complications of PPI? So if a patient takes PPIs for a long time, it can lead to certain conditions or certain diseases. What are some of those diseases? 5 you need to know for your exam. Can you tell us 5 long-term complications of PPIs? Tell us in the comment section. Tell us in the comment section. So I can see one already. Good. So one is from Amjad. Amjad says C. diff. C. diff, Clostridium difficile infection. So C. diff infection is a GI infection. So which means that PPIs can increase the risk of GI infections. That's one. Number two is PPIs can mask the risk of can mask gastric cancer. PPIs can mask symptoms of gastric cancer. So a patient might have gastric cancer and they won't even know. They won't know because they are on a PPI. PPIs can lead to osteoporosis. PPIs can lead to osteoporosis. That's true. And someone says PPI can lead to hypomagnesemia. Correct. PPI can lead to hypomagnesemia. So PPI can lead to low levels of magnesium. That's correct. And then finally, PPIs can lead to lupus. Lupus is an autoimmune disease which can cause disfiguration of the skin. Yes, it can lead to lupus, correct. With hypomagnesemia, though, you need to watch out for hypomagnesemia and something like digoxin. Remember, we talked about this before. So with digoxin, there's 4 electrolyte imbalances you need to know for your exam, which are hypomagnesemia, hypokalemia, hypoxia, and hypercalcemia. You see, so any of these can potentially lead to digoxin digitalis or digoxin toxicity. So you need to watch out for drugs that can potentially cause hypokalemia, drugs that can cause hypomagnesemia, hypoxia, and drugs that can increase calcium. So if something like vitamin D, for example, high levels of vitamin D can lead to hypercalcemia. Good. Next, we'll look at another one, which is quinolones. We will look at quinolones like ciprofloxacin or floxacin, which have multiple uses. Quinolones have multiple indications in the BNF. They cause a whole bunch of issues like tendon damage, for example, and some of the things we're going to look at in a second. But what they've added now is that quinolones can increase the risk of heart valve regurgitation. They can increase the risk of heart valve regurgitation. This is brand new. This is something they've added recently to the BNF. So you need to make note of that. So if a patient is at risk of heart valve regurgitation, it's best not to put them on a quinolone. We have to look for an alternative. We have to look for an alternative antibiotic. Yes, because they can increase the risk of heart valve regurgitation according to new research. There's a question there for you. Which of the following is not caused by quinolones or not associated with quinolones that you know of? Which of them, A, B, C, D, or E? Which of them is least likely? In other words, which of them is least likely associated or caused by quinolones? Okay, so just one answer for this one, which means a lot of people are not sure. You need to know your quinolones inside out. I'll help you cover it quickly, but you need to cover your quinolones inside out before you see this exam. It's very important. Group of antibiotics with loads of drug interactions and side effects you need to know for your exam. So the correct answer is D, yes. So Rab, I think this is Rab. Rab says D, which is urine discoloration. Which is urine discoloration. We know some antibiotics can discolor urine. Yes, we know that. But quinolones don't necessarily discolor urine. We don't. It's not recorded or it's not well known that quinolones would discolor urine. So D is the answer. But everything else is associated with quinolones. QT prolongation. We just talked about that. Yes, they may affect blood glucose. So they can actually increase blood glucose. If a patient was diabetic, we have to be careful. We can use quinolones, we have to use it with caution because they can increase the levels of blood sugar. They will cause tendon damage. Yes, yes, this is one of the most popular side effects of quinolones. They cause tendon damage, especially in elderly or older patients, especially in older patients over 60. Patients over 60 are at an increased risk of tendon damage. They would interact with warfarin and lead to increased risk of bleeding. They can interact with warfarin and lead to an increased risk of bleeding. Yes, so the only option there that's not connected to quinolones is D. So D is the correct answer. Yes, well done. Okay, so now which OTC medicine would you avoid if a patient is taking quinolones? Which OTC medicine would you avoid and why? Which OTC medicine, if a patient is taking quinolone with ciprofloxacin, for example, which OTC medicine would you avoid selling to them and why? Which one and why? Tell us in the comment section. Which OTC medicine would you avoid and why? Correct. Correct. So someone, I'm not sure what your real name is, but you go by Hotel Alpha. It's brilliant. Says NSAIDs. This person says they will avoid selling NSAIDs to someone on quinolones because it can increase the risk of seizures. Fantastic. Fantastic. So quinolones and NSAIDs would interact and it could increase the risk of seizures. Now, what you need to know is without taking an NSAID, quinolones on their own can increase the risk of seizures, even without NSAIDs. Now, if you add NSAIDs to it, it would then make that risk even greater, especially because NSAIDs reduce the excretion of drugs via the kidneys, right? So they reduce excretion of drugs, so you can potentially have a higher level of the drug circulating in the patient's system. So without NSAIDs, they could, but with NSAIDs, they increase the risk of seizures even more. So that's correct. That's correct. Yeah. So with quinolones, no, that can affect the growth of children. So we can use it in children, but we have to use it with caution because they can affect the growth of children. Clearly, if it's something like tetracyclines, for example, we should avoid tetracyclines in children under what age? Under what age should we avoid the use of tetracyclines in children? What's the age limit for tetracyclines in children? With quinolones, we can use quinolones in children with caution. So you will see ciprofloxacin, oral suspension, things like that. We can use it with caution, even though it can affect the growth of children. But with tetracyclines like doxycycline, um, lamicycline, we have to use it in children over the age of 12. Use in children over the age of 12. Yes, well done. Why? Because it can be deposited, again, affect their growth and can also be deposited in their bones, can also be deposited in the bones of children. So use tetracyclines over the age of 12. That's a classic GPHC exam question. Classic GPHC exam question. So everything else is in this question that they like to ask, besides obviously option D, which is wrong, but QT prolongation, blood glucose, tendon damage, interactions with warfarin, interactions with NSAIDs, interactions with steroids. So they would interact with steroids, you know that, and increase the risk of tendon damage. They are all here. Yes, most of the things they like to ask are all here. Good. Next, we'll look at a question for you, which is another drug that you need to know about for this exam. Inside out. You need to know this drug inside out. So tell us what you think the correct answer is for this question. Okay, so first question is, which drug is this? The patient doesn't know the name of the medicine they are taking, which is something you find in community pharmacy. Some patients don't know what medicine they are taking, but what medicine do you think this is? What is the name of this drug that this person is taking? Warfarin, correct. Warfarin, this patient is taking warfarin, correct. Okay, so now, if this patient is on warfarin, how long before an elective surgery do you need to stop warfarin? Which is basically what this question is asking you. How long before an elective surgery do you need to stop warfarin? The answer is C. The answer is C. C is 5 days. So 5 days before surgery, we need to stop warfarin. 5 days before surgery, we need to stop warfarin. Now, the new guidelines says we should use warfarin as second line. Okay, so in patients who have things like atrial fibrillation, atrial flutter, we are going to be looking at chapter 2 this weekend. For anyone who's joining the session, we're looking at chapter 2 on Sunday from 11 o'clock in the morning, and we're going to look at this in more detail. But the new guideline says warfarin should be used as second line, especially in patients who have atrial fibrillation and atrial flutter, because atrial fibrillation and atrial flutter can predispose the patient to coagulation, so their blood can potentially clot. Okay, so for that reason, a lot of patients who have atrial fibrillation and atrial flutter are prescribed an anticoagulant. So now we have to use the novel oral anticoagulants. Novel oral anticoagulants. Before we talked about rivaroxaban, edoxaban, dabigatran, and apixaban. So those are the four we need to use. But warfarin has been moved to second line. Okay, now part of the reason is because of all the monitoring requirements that go with warfarin, INR checks, and loads of interactions. Warfarin has so many interactions. Oh my God, so many interactions you have to remember with warfarin. Um, Patients are not allowed to eat certain things. What sort of things are patients are supposed to avoid whilst on warfarin? What sort of things are patients supposed to avoid eating or drinking whilst on warfarin? Can anyone tell us? Can anyone tell us what sort of things patients on warfarin are supposed to avoid eating or drinking? Tell us in the comment section. Yes, 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 yes. So first of all, cranberry juice. So you've got cranberry juice, that's very important. Cranberry juice, pomegranate, that's another one. Pomegranate juice or pomegranate powder, anything that has pomegranate in it, they should avoid ideally. Cranberry juice, the same, even cranberry powder, because you know, in OTC sachets for cystitis, some of them are flavored with cranberry powder. You know that. So if a patient is on warfarin, they should avoid taking sachets like that as well, because they have cranberry powder in them. Green leafy vegetables, very good. Green leafy vegetables in one of the recent exams, I think they gave options of different vegetables, and they expected the students to choose which vegetable, obviously a green leaf vegetable that would interact with warfarin. Yeah, so you need to know examples of green leafy vegetables for your exam. Yes, so you know green leafy vegetables, but you also need to know examples of green leafy vegetables. Alcohol, large quantities of alcohol can also affect people taking warfarin. Large quantities of alcohol. So you have green leafy vegetables, pomegranate juice, cranberry juice, cranberry powder, and you have large quantities of alcohol. Those are the four things they need to stay away from. Whereas some of the novel oral anticoagulant drugs, you don't need to do these things for them. You don't need to monitor their INR. They can eat, obviously, eat in moderation. Um, They're more expensive. They're more expensive. So something like apixaban, for example, a box of 56 can cost somewhere between 30 to 40 something pounds, whereas warfarin costs about £1, £1.50 maximum. So there's some cost issues, but expect to see which one of the following is an advantage of a NOAC over warfarin, or which one of the following is a disadvantage of warfarin compared to the novel oral anticoagulant drug. That's a classic GPHC exam question, especially now because they're pushing for the NOACs to become first line compared to warfarin, which is what we used to use before. If a woman is pregnant, what type of anticoagulant can we give to a pregnant woman? Anticoagulant in pregnancy. Which anticoagulant would you give a woman in pregnancy? Which anticoagulant would you give in pregnancy? You can't give warfarin clearly because warfarin can cause teratogenic effects. We can't give warfarin, but we can give low molecular weight heparin. So Sophie says low molecular weight heparin. Correct. So low molecular weight heparin will be things like enoxaparin, for example, which is Clexane injection. We can give enoxaparin, which is a low molecular weight heparin. Why? Why is this better for patients who are pregnant? Why is this better? It's better because it doesn't cross the placenta. It does not cross the placenta. So something like enoxaparin doesn't cross the placenta. So if it doesn't cross the placenta, then it has less chances of affecting or harming the unborn child. Less chances of crossing and harming the unborn child. Now, with low molecular weight heparin, you need to give or dispense or prescribe by brand. They have to be prescribed and you have to dispense by brand because they are an example of biological medicines. Biological medicines. So when you get your BNF, look at the first few pages, which is something you need to read at least once before your exam, and it tells you about biological and biosimilar medicines, and it gives you examples. So things like monoclonal antibodies, for example, biological and biosimilar medicines, it talks about in the first few pages of the BNF. You need to read those pages, about 30, 40 pages before the BNF, before chapter 1. You need to look at those pages at least once before your exam. So it talks about biosimilar and biological medicines, which low molecular weight heparin is an example of, which you have to prescribe by brand. You have to prescribe by brand. Other medicines that you need to prescribe by brand include what? What other examples do we have to prescribe by brand? Lithium is one of them. What else you have to prescribe by brand? What else do you have to prescribe by brand? Yes, theophylline you have to prescribe by brand. Beclomethasone inhalers, fantastic. It's a very good example. So something like Cuva and Clenil, for example, have different size particles. One of them has the finer particle than the other one. So for that reason, we have to prescribe it by brand. Very good. Cyclosporin, very good. Cyclosporin came up in a recent exam, so expect to see cyclosporin again. Cyclosporin should be prescribed by brand. Patients on cyclosporin should avoid direct sunlight. Which juice should patients on cyclosporin avoid? Patients on cyclosporin should avoid a particular type of juice. What type of juice should patients on cyclosporin avoid? What type of juice should patients on cyclosporin? Grapefruit juice, fantastic. Grapefruit juice should be avoided by patients on cyclosporin. Thank you. So yes, so drugs like lithium, drugs like carbamazepine, drugs like diltiazem over 60 milligrams. That's another good one. Diltiazem over 60 milligrams. The anti-epileptic category 1 drugs. So anti-epileptic category 1 drugs like carbamazepine, phenytoin should be prescribed by brand. They should be prescribed by brand. Drugs like tacrolimus, prescribed by brand. Yes, so very important for you to know examples of drugs that should be prescribed by brand. This one is from 60 milligrams and over. 60 milligrams and over should be prescribed by brand for diltiazem. Very good example. Good. Next, we'll look at new guidelines on SSRIs and SNRIs. Now, this is the first line choice for depression. This is first line choice for depression. So historically, we started off with monoamine oxidase inhibitors and moved on to TCAs. Then we moved on to SSRIs and SNRIs. So obviously with monoamine oxidase inhibitors, there was loads of drug interactions, loads of side effects. You remember the cheese effect from university? So that is when a monoamine oxidase inhibitor interacts with certain food containing high levels of tyramine. High levels of tyramine, so things like marmite, things like soya beans, things like anything that's going off, going stale, like beef or poultry is going off. Um, would have high levels, even like old vegetables or old fruits like banana, for example. When banana is really ripe and it's beginning to go black in color, the outside, you potentially have higher levels of tyramine compared to an unripe banana. So you need to know that for your example. What we want to talk about today is SSRIs and some of the effects of SSRIs, some of their side effects and drug interactions. So the new guidance on SSRIs is that we need to be aware that SSRIs can increase the risk of bleeding if used a month before delivery. So postpartum hemorrhage, that's bleeding by women who have just delivered. Yes, so if an SSRI or SNRI is used a month before delivery, it could potentially increase the risk of bleeding but of the mother, not the child. Now, when we look at on the 26th of June, I'm going to be covering chapter 4. I'm going to be covering chapter 4, and we'll look at epilepsy and anti-epileptic drugs and their effect on the unborn child, right? So we know that anti-epileptic drugs can cause hemorrhagic newborn disease. Hemorrhagic newborn disease. And for that reason, we give vitamin K injection. Yes, we give vitamin K injection to the newborn child. Before delivery, we would give vitamin K supplements, either tablets or maybe injections to the pregnant woman. So we'll give vitamin K supplements to the pregnant woman around 8 months of pregnancy to reduce the risk of hemorrhagic newborn disease. So what you're saying now is that SSRIs can cause the same thing. This is bleeding of the new mother, so postpartum hemorrhage. So new mothers can potentially bleed if an SSRI or SNRI is used a month before delivery. Question here for you on antidepressants. Tell us what you think. Okay, so what do you think? Tell us what you think about this question. This is a very good question. It's a very good question. You have to know your stuff to get this question. This is not kindergarten question. This is top notch. This is questions for people who really know their stuff, who have gone looked at your BNF, looked at your NICE guidelines. You need to know your stuff to be able to get this question right. Okay, so this question says a 21-year-old patient, that's an adult to begin with, right? So this question is talking about an adult. So this person is suffering from depression, started 6 months ago. As per NICE guidelines, we have to offer non-drug form of therapy. So things like CBT, for example. So we have to offer things like CBT, things like counseling to help the patient cope with depression. Depression is a big problem now in the UK, especially with this lockdown. There's a lot of people depressed. So don't be surprised to get questions on depression and antidepressants in your exams. It's extremely important for us to be aware. A lot of emphasis is being laid on mental health conditions right now in the UK, which is brilliant. Okay, so this patient is 21, so he's an adult. He's depressed. Depression is getting worse. He's showing signs of suicidal behavior, exhibiting signs of suicidal behavior. His specialist wants to prescribe him a new medication. Which one of the following is the most appropriate for him to prescribe? Now, if you look at it, about 3 of them are actually SSRIs. So you have sertraline, you have fluoxetine, you have citalopram. And then you have something like mirtazapine and amitriptyline. The correct answer to this question is B. Correct answer to this question is B, and I will explain. Now, if you look at the guidelines properly, actually read the new BNF properly, in the pages preceding antidepressants, it would tell you that antidepressants can actually increase or worsen the risk of suicidal thoughts and behavior in people in general. So when people have depression, you give them SSRIs, they help. However, they found through research that if the person has depression and they have signs of suicidal thoughts or suicidal behavior, SSRIs or even SNRIs or even TCAs can potentially make it worse. So for people like that, we have to give mirtazapine as first line because of suicidal thoughts and behavior, which mirtazapine doesn't tend to worsen. Does that make sense? Yeah, so mirtazapine is first line for people who have depression that's accompanied with suicidal thoughts and behavior. Now, another popular question would be if this person was a child, for example, if this person was under 16. If it was under 16, they would then ask you which of the following antidepressants is first line for people who are under 16. The answer then would be fluoxetine. The answer will be fluoxetine. So if the person is under 16, fluoxetine is better because fluoxetine has the least risk of increasing risk of suicidal thoughts and behavior. Okay, so it's different depending on the age of the patient. It's also different depending on the circumstance. So if the person has suicidal thoughts and behavior attached to their set of symptoms. Hope that's clear. Now, mirtazapine can also cause blood disorders. Yes, mirtazapine can also cause symptoms of blood disorders like bleeding, bruising, purpura, sore throat, fever, unexplained bleeding, probably said already. So if a patient is on another medicine, so this 21-year-old could have been on something else that could also cause blood disorders, like carbimazole, for example, can cause blood disorders, etc., etc. So then the specialist might have to look at another option, but they are not. Okay, so B is the correct answer to this question. Next is ulipristal acetate. Ulipristal acetate changes to this drug. So there are 2 strengths normally, the 5 milligram and another strength that's used for contraception. What's the strength used for contraception? There's a brand called Ella1. Ella1 is a contraceptive, emergency contraceptive. What's the strength of Ella1? What's the strength? 30 milligrams. Thank you. 30 milligrams is used for contraception, whereas 5 milligrams is used for what? What's 5 milligrams used for? 5 mg is used to treat what? So we know 30 milligrams is Ella1 for contraception, and then 5 milligrams is used to treat what? What is 5 milligrams used to treat? Fibroids. Fibroids. So 5 milligrams is used to treat uterine fibroids. Uterine fibroids. Now, the new guideline is saying that ulipristal acetate 5 milligrams can cause symptoms or can cause liver injury. They can cause liver injury. So now it's being restricted. It's hard to get hold of right now because they're looking into this. They're trying to research to see if there's anything it can possibly do or if the medicine is going to be withdrawn from the market completely. But LR1 is still available because LR1 is meant to be for a one-off use. LR1 is meant to be for a one-off use, whereas the 5 milligram the patient is supposed to take every day for potentially a longer period of time to treat uterine fibroids. Uterine fibroids. So that brand, Enzema, I think the brand is called Enzema, 5 milligram ulipristal acetate, has been withdrawn temporarily from the market because of risks of liver injury. Because of risk of liver injury. Okay, next we'll talk about aminoglycosides. Aminoglycosides, we sort of already know this because you know that aminoglycoside can increase the risk of deafness, can increase the risk of deafness, or they can cause hearing impairment in patients, period. We know that before now, but they've added an extra information, which is increased risk of deafness in patients with mitochondrial mutations. Increased risk of deafness in patients with mitochondrial mutations. That's just an extra point. But in general terms, you do know that aminoglycoside can cause ototoxicity, they can cause nephrotoxicity, and gentamicin in particular can cause histamine-related adverse reactions. Histamine-related, which is new, about 2-3 years old, histamine-related adverse reactions. So, so you do know that, and you do need to know about the monitoring of aminoglycosides, narrow therapeutic index drugs they are. So you do need to monitor something like gentamicin, for example. We need to monitor peak and trough levels of gentamicin to reduce the risk of toxicity. So you do need to know that for your exam. Extremely important. Human and animal bite. Yes, I like this one. I asked this question in all my mock exams and came out as well. Came out not last year, it wasn't an exam last year, the year before last. Came out in both exams. Apparently, you need to be aware of that section in the BNF before, at the beginning of chapter 5. At the beginning of chapter 5, where it talks about prophylaxis and therapy, you do need to go over and learn as many of them as possible. So first line treatment for things like hospital-acquired pneumonia, community-acquired pneumonia, otitis media, otitis externa, shigellosis, human bite, animal bite, which is practically the same treatment, etc., etc. So you would get at least 2 questions from there. Now, in this new BNF or BNF Online, they've added that we can also treat by IV. So in the old BNF, if you look at your old BNF, it talks about oral treatment, which co-amoxiclav is the first line for oral treatment. Co-amoxiclav is the first line, whereas for IV treatment, which is something new they've added, first line is still co-amoxiclav, and the second line is cefuroxime, which is a cephalosporin combined with metronidazole IV. Okay, so this wasn't there before. They've just added this IV treatment to it, but the first line still remains the same, but the second line is different. Second line is different. So you do need to have a look and see in your BNF what the second line would be if a patient is allergic to penicillin. What would the second line be if a patient is allergic to penicillin? Just say the patient was supposed to have an antibiotic orally because they've been bitten by an animal, say their cat, for example, or their dog. What would the second line be if the patient was allergic to penicillin? That's something you need to know for your exam. And also, what's first line? What's first line treatment in human and animal bite in children? So when you look in your children's BNF, the first line for children is different to the first line for adults. So does anyone know? I've just asked you two questions for patients who are allergic to penicillin and they want to receive an oral treatment. Because obviously for IV treatment, the BNF says we have to refer to a specialist. But for oral, what would you give if a patient is allergic to penicillin? And then secondly, what is first line treatment for human and animal bites in children in your children's BNF? So two questions. If you know what the answers are, let us know in the comment section. Let us know in the comment section if you know what the answer to those two questions are. Let us know if you know what the answer to those two questions are. Okay, correct. Yes. So um doxycycline and metronidazole, a combination of those two would be second line. So for patients who are allergic to penicillin, for someone who's allergic to penicillin or someone who doesn't tolerate coamoxiclav, would give doxycycline and metronidazole orally. Yes. What about children? Did anyone check children's BNF to let us know what first line for human and animal bite, what the first line treatment is in children? Did you look in your BNF and let us know first line for human and animal bite in children? That's the second question I asked you. So I'll move on, but if you find that answer, let us know in the comment section. But I'll move on because of time. Next, we'll look at epilepsy. Epilepsy is obviously important for you to cover for this exam. Chapter 4, updated advice on anti-epileptic drugs in pregnancy. So with epilepsy in pregnancy, we need to encourage pregnant mothers to report to the epilepsy pregnancy register. Epilepsy pregnancy register, they need to report, right? So they need to be given advice. They need to ensure that they are taking the right medication and the right supplements. Something like folic acid, 5 milligrams, for example, needs to be taken by women who are on anti-epileptic medication. Extra emphasis on sodium valproate. Yes, so you know the big thing now is sodium valproate and the effects of sodium valproate on women of childbearing age. And as part of this, you need to know about PPP. You need to know about PPP, which is Pregnancy Prevention Program. So you need to know about PPP and the 4 drugs. What are the 4 drugs that we need to ensure that patients are on the PPP program whilst taking? 4 drugs, Pregnancy Prevention Program. Yeah. What drugs, 4 drugs do we need to ensure that patients are on this program whilst taking pregnancy prevention programs? 4 drugs. One of them is sodium valproate. Can you tell us the other 3? The other 3 examples or group of drugs that patients need to be on the PP program. PP program is pregnancy prevention program. Sodium valproate, yes. What about the other 3? What about the other 3 drugs? Good, yes. So Amidat Ismail says oral isotretinoin. Isotretinoin and the vitamin A analogs. Because it's not just isotretinoin, right? So isotretinoin is an example of a vitamin A analog, but there's also other ones as well, like acetretinoin. You can tell from the name, like acetretinoin. It's another type of vitamin A analog. So isotretinoin and the vitamin A analog, because as you know, vitamin A should be avoided in pregnancy because high levels of vitamin A can be teratogenic. So isotretinoin and the vitamin A analogs, yes. Sodium valproate, yes. What else? I need two more answers from you. Two more answers. Two more answers. Does anyone know? Tell us in the comment section. Two more answers if you know what they are. No? Okay. I'll tell you then. So last two are mycophenolate mofetil. Mycophenolate mofetil and thalidomide. Obviously, thalidomide is a drug that's very difficult to get because of what happened in the 60s. Um, but if you do come across this drug for some reason, then we have to make sure the patient is on the PP program. So mycophenolate mofetil, thalidomide, which will be very difficult for you to get hold of. But if you do, somehow the patient needs to be on the PPP or the PP program, pregnancy prevention program. So those are the four. Yes, sodium valproate, isotretinoin, and the vitamin A analogs, mycophenolate mofetil, and thalidomide. Those are the four drugs you need to know. Recent research obviously showed that levetiracetam and lamotrigine are the safest in pregnancy now. Safest in pregnancy now. So once again, if you've just joined us, there's a link in the description area where you can see where all these changes came from. So you can obviously have a look, do more research on your own, do more reading on your own. This session is a summary of what I think is important for you to know for your practice and for your exam. So the recent studies show that levetiracetam and lamotrigine are the safest two in pregnancy. So obviously they all carry a risk in pregnancy, side effects, drug interactions, potential harm to the unborn child. But apparently levetiracetam and lamotrigine are now known as the safest in pregnancy. Okay, next I have a question for you. What is the answer to this question? What is the answer to this question? Fantastic. Yes. So the correct answer, Sean says the correct answer is topiramate. Topiramate. So this person, chances are that this patient's mom was probably on topiramate whilst they were pregnant. And as a result, they've ended up with this condition here. What's this condition called? What's this condition called? This condition has a name. Cleft palate. I like that. Yes, that's the correct name. Cleft palate. Yes, so cleft palate is the condition displayed by this child. Unfortunately, it could be as a result of the mother taking topiramate during pregnancy, especially in first trimester. Especially in the first trimester of pregnancy, it could be as a result of topiramate in first trimester of pregnancy. So the answer is D. Well done. Next, we have a session on Sunday. A session on cardiovascular events on Sunday, on chapter 2 with questions, etc., etc. Myself and Siddiqa are going to be covering chapter 2. For anyone who's interested in joining, you can send us a message if you wanted to join, and we're going to cover chapter 2 in a lot of detail on Sunday. And a reminder for people who have signed up already to join us at 11 o'clock on Sunday. But I'll end today's session. Here, and I just wanted to recap very quickly what we've talked about for anyone who didn't join us from the very beginning. So we looked at these drugs, not very many changes, but These ones, obviously, drugs that we come across every day and drugs that potentially come up in the exam. Um, I'm not expecting to see more than a couple of questions from here anyway. But if you do, the GPHC wants you to use the latest available guidelines. So these are the drugs we talked about. Glibenclamide, there's an issue. I didn't really go over glibenclamide, which is a long-acting sulfonylurea. There's an issue with glibenclamide now, where the manufacturers are trying to withdraw glibenclamide from the market. Obviously, in pregnancy, it can only be used in second and third trimester, but even that is still being looked at so far. It's still being looked at. So when you look at the link in the description area, you can have a look and see for yourself. But glibenclamide is going to be potentially going to be withdrawn. Yes, so this is what we looked at today. I hope you found today's session useful. Um, if you wanted to join, for anyone who's new, wanted to join us on WhatsApp or Telegram or Facebook or join our revision, do send me a message and let me know. If you haven't subscribed to this channel, do subscribe. I'll do free sessions like this from time to time, just to keep you educated, but also to help people who are preparing to sit their exams. You can follow me on Instagram, London Pharmacist Network, and you can send me an email if you have any questions, if you would like me to answer any of your queries. My email address is on the screen. But I'll end this session now, and I would like to thank everybody. Give us a thumbs up for this video if you enjoyed this video. Um, I would like to thank everyone who joined us today, and hopefully I'll see you soon. Have a lovely weekend.